Same patient, with morbidly obese patient, was initiated ECMO in some other hospitals and retrieved here. Patient had during shifting hypertension and hypovolemia was there, which was managed well. After shifting, patient was doing well, so extubated after 4 days. Then developed right heart failure after 10 days, required to be put on inhaled nitric oxide and milrinone and inotropic support. Had an AKI also, but then that recovered very well. After that, patient developed clot in the pump, and because of that, we need to change the pump. So pump was changed yesterday. ACT target was kept initially about 160 around, but then because there's a clot in the we need to increase the ACT target. Yesterday we have changed the pump, and patient was given, even patient had bradycardia and near cardiac arrest, so cardiac massage was also given to the patient. Okay. Now it's after that the parameters you can see on the scope.
Yeah.
It's over to you. It is just ACT target now we is increased to 180 to 200. Okay. Over to you now.
So, what is the blood gas, sir? ABG?
ABG in the morning shows pH of 7.34, PO2 is around 55, PCO2 is around 38, and bicarb is around 22.
So consciousness of the patient, because
Patient post arrest we have not assessed him, but pupils are bilaterally equally reacting to light, and it was witness arrest. It was not complete arrest, it was basically in bradycardia. Heart has gone down to almost around 10-15. So
trend of the pressures, sir. Trend of the ECMO pressures.
yeah, that remains almost the same.
Almost the same.
Inotropic infusion, sir. Inotropes.
Inotropes is on noradrenaline of around 0.05 max per kg.
Renal parameters.
Sweep gas flow, sir.
Sweep gas flow is 3 liters.
Renal parameters, sir. Renal parameters.
Renal parameters, creatinine is around 1.9. Okay.
Other labs, sir. CBC and all. Anything has been repeated today?
CBC hemoglobin is around 9.3, and platelet count is around 80,000, and your WC count is 13,400.
Urine output, sir.
50 ml per hour.
Cardiac status.
Have you done any ECMO post cardiac arrest?
Yeah.
Cardiac
Have you done
2D
any
echo, 2D echo.
2D echo we have not done it.
And any X-ray has been repeated for the patient?
for the patient?
No, not now, not recently.
Temperature
It's normal, 37 degree.
Just check
The flows.
everything is fine.
From patient.
yeah, just we will check with the circuits connection, and we will also check everything is fine with the patient.
Ventilator settings on the rest ventilation settings only.
You are looking for the patients.
Yeah, FiO2 is
Where is the platelet count?
100%.
Color of the tube.
Small drop in saturation suddenly.
Yeah,
So I'm coming up on the FiO2,
Okay.
ventilator FiO2.
Ventilator,
We can accept the saturation of 80.
Yeah, check the color of the tubes, both the cannulas.
both the cannulas appear
Almost
same.
yeah,
Connection is good.
No kinking, no obstruction in the
Delta pressure normal, P1
ventilator FiO2 can be turned
Is
down
it
to
becoming the
100%.
same color?
Can we increase FiO2 to
Okay.
100, sir, in the ventilator?
adequate sedation is going on or not, we should check.
Check whether the sedation is.
Saturation is dropping down to 85.
Flows
The
are the same.
ventilator settings have been.
Flows are maintaining.
P1 is mildly.
Yeah, P1
P1
has
is minus
gone up.
61.
Gone up.
Actually.
More negative it is becoming.
So P1 is more negative and
ECG,
There is
there
no
are some
chattering.
rhythm disturbances.
Heart rate
pattern
has
we can
increased.
The
Saturation going
saturation
down.
is dropping yet.
We'll give some fluids and see now.
see. Yes.
Is there any malfunction in the mechanical thing?
It should be the
Can you check with the
Torch.
ECMO machine, please?
What do you want to check?
The flows
Connection with the oxygenation, like blender and
pump.
sweep gas.
Can you give some fluids as the P1 is slightly
Connection is fine.
becoming more
Become
negative?
more negative.
Negative. We will
Okay.
give fluid
To around 250 ml.
250 ml and
Is more negative.
You want to
There's
give
no
fluids?
chattering. Also.
Clot
But
in
there
the
is no
can,
chattering
that
as
could be
such.
the reason.
Drainage canal is fine, right?
The internal.
There is no chattering as well.
Can we get an X-ray, sir? X-ray for the
You want to
patient?
see X-ray?
Yes, sir.
The patient had cardiac massage, then after that we haven't got any X-ray.
X-ray and want to check the cardiac status as well.
FiO2
echo.
is not connected for this.
Correct.
Sir, you
See-
said platelet count is 18,000.
80.
80.
80.
Can we
ACT is
increase
around
the
180.
flows?
Hypotension, little bit of BP is coming down.
Oxygenation is improved to 100% FiO2 in the text.
So
just X-ray.
with the previous X-ray when compared, can we have a comparison, sir? Like
It has
The previous
worsened
X, it has
actually.
worsened actually.
White
More
out.
white out.
Can you increase the FiO2 on ventilator, please?
we have increased. I asked for.
Change in the
And this one also, ECMO also it's full.
ECMO FiO2, it's disconnected.
It's
No,
100%
not
connected. Connected.
It is also
showing
increased.
21.
And
So delta pressure is still 36.
This was the previous X-ray.
endotracheal tube position and adequate sedation we need to ensure. So
On
There is-
X-ray,
more or less.
The worsening of the chest X-ray is fine.
There more whitening
More
of the
white.
chest X-ray.
This was previous X-ray and now
Yes, sir.
There's
So now
hypertension
it's
also.
hypertension also.
flows are okay.
Can we get a focus done and see the cardiac
Yeah,
status?
Yes, sir. Cardiac echo.
Can we increase
will
the
be- because
support
immediately
You can
yesterday
increase the
had an
support
Support
also.
of the support.
Yes.
The
Sir, we need to
vasopressor
increase the inotropic support, increase non-adrenaline to 0.1 mics per
this is
kg per
X-ray.
minute.
Yeah.
Okay.
You want to increase noradrenaline?
Yes, sir.
Yeah, we want to increase the noradrenaline
the
to
To 0.1 mics per kg
Now I want to
per minute.
check the ABG, sir. Lactates and all, acidosis.
Okay.
Membrane.
And ventilatory settings of FiO2 100, sir.
You want to go up on ventilator settings?
It's FiO2, only on FiO2, sir.
Okay. Why?
So also,
the hypox. There is a decrease in the saturation in
can
the
we
patient
increase the flows?
as well as
No chartering.
worsening of the ventilator.
Now
Everything is in place.
Fine,
Sir,
Nothing fault is found.
250 ml of bolus fluid, sir. It was given earlier or?
250 ml of fluid given. Not much response.
ABG, sir. Current ABG. Now,
Current
now we
ABG.
want to take an ABG.
Yeah. pH is around 7.28. PO2 is around 48. PCO2 is around 40. Bicarb is 18. And
Lactates.
lactase 2.1.
PCO2 is 14, 1 4.
40.
48.
From 38 to it's 40.
tachycardia, hypertension.
Earlier it is
go up
28.
on the flows.
Earlier it is
We'll
28
go-
in the morning. ABG.
Yeah.
PCO2.
PCO2 was almost same. 38.
Same,
Now
same.
this is 38.
38.
PO2 was 55. It has come down to 48.
We'll go up on the flows and see. Focus,
Focus of the lung.
any
Focus was a right side massive pleural effusion with septation, query hemothorax.
Hemothorax post.
Post cardiac arrest.
Cardiac massage, and the patient is
So
on
I think-
anticoagulation. There is a
Very
very
chance of
that
Yes, sir.
Since that
So-
hemothorax is affecting the venous return, can we plan for an intervention?
What intention you want?
ICD placement for
Before that, we can cut down on heparin as it will
Come down.
worsen the
The-
bleed.
Yes, come down on heparin.
We can cut down. I mean, we can
ACT
stop heparin.
values we will target around 160.
140.
So tell me what you want to do.
Stop heparin, sir.
Stop heparin?
Yes. Sir.
Okay, I stopped heparin. Okay, fine. Then
Then
Frequent checking of ACT every 4th hourly.
It's okay. Next.
and repeat HB,
Should we
sir.
intervene with
Repeat
placing
HB
ACT?
if necessary.
They
Give a
should
intervene.
give it a
transfusion.
transfusion of blood.
first with
HB is 8.6.
Yeah, better give a transfusion.
Give one transfusion of PRBC, sir.
Okay.
For ICD, we need to keep ready things for ICD.
ICD will cause more bleeding.
PRBC is order. It will come in half an hour.
But at this moment, as BP is low and sepsis are going down, it's better to intervene.
should we consider an ICD? Like, so
Yeah.
because it is affecting the
Affecting
venous
the-
return and it's
Causing
affecting the
hypertension.
So we just
Hypertension
stop the
also.
ACT values.
We'll
Yeah,
recheck the ACT values.
We check the ACT values. and
Recheck
then
the
we
ACT values.
ACT is 150 now.
ACD
After stopping heparin.
We can consider.
Yeah,
ICD.
consider
We can
putting an
consider for
ICD.
putting an ICD.
You want to put ICD?
Yes.
Yes.
Give them ICD.
But before planning
Who is
for
going to put ICD?
We need to
before planning for an ICD, we'll discuss whether ICD is actually immediately required or not.
Yeah,
And
so you can see
is there
BP
any
is going
possibility?
down and saturation is also going down, which will affect with the venous return. So by
No, we'll try a transfusion, one transfusion,
one more
and if the
transfusion and
vitals
then
are stable, then we can plan. We make ready for the ICD,
we'll
then we
for
can plan
ICD,
for.
but if
But
the
we'll-
vitals haven't stabilized, then we'll go ahead. That
And
will
we
be the
can-
last step because on ECMO and with
And
ACDs
we can do
and
serial
No.
ultrasound also.
No.
to-
what is the HB on ABG, sir? HB on ABG?
HB on ABG is 8.6.
It's dropping from the previous age.
yeah, that's what we have
Yeah.
given one transfusion. We can also plan one more transfusion, one PRBC again, so that we'll see if the BP has increased or the hemodynamics have stabilized a bit. So preferably PRBC transfusion, one more transfusion we can
transfuse
plan
one
as
more PRBC.
there were placing an ICD as sir told
Okay.
that there is septations and everything. So,
So-
even in the
So
position of
we'll,
the ICD should
correct
be also
the
discussed.
coagulopathy, we'll correct the hemodynamics, then we'll think about
And
the.
under focus guidance, we have to do that ICD placement as well.
Oh.
We'll
That
transfuse
will
one more PRBC, sir. We will
Second
transfuse
PRBC.
You want to
is-
give second PRBC?
second PRBC
Okay.
transfusion.
And
and
Second
wait.
PRBC given.
and titrating noradrenaline infusion, sir, to maintain MAP more than 65.
So now it
Should
is
we
0.1
increase the
micrograms.
It's
per
point
kg per
We'll
one.
liter.
increase
If
to-
one, we can add
Because
so
systolic is less than 90.
82 saturation is
There's no problem with the drainage
we
cannula
can
if clot
increase
has
the
been.
sweep
Yeah.
flow.
No, no
FOT is
bleed
100
or
anyway.
Even circuit pressures were almost same.
The
No
circuit
change in
pressures are
circuit
same.
pressures.
The color is also fine.
Color is also fine.
Color is
No
also
kinking
fine.
of the
There is
canula.
measure-
Delta P is around 36,
it is-
not with a circulation problem, rather patient-related problem
Patient related
is more.
problem only.
More less of a mechanical problem.
So
rather
went
than a
up on
patient.
inotropes, given 2
Two
transfusions.
places. Now
What
BP
is
is
the urine
coming
output,
good,
sir? Urine
but
output.
saturation is
Urine
not
output 50 ml per hour.
Can we send a rotum and correct if any coagulopathy is there for the patient?
Okay, we are
Like
saying to
ACT
rotom,
is
it will take half an hour time to come.
ACT is
ACT
150.
is
There is
150
ACT
says.
one set is 150.
Because there is no evidence of bleeding, so
Ongoing bleed means you have to correct the coagulopathy.
We have stopped heparin for now.
But there is a massive pleural effusion, there is no space for the lung to expand
Yes,
also.
better we go for
an
ICD now,
ICD.
because
Yeah,
even
after
after,
transfusion also we can't see any significant
yeah,
improvement
pressure
in
remains same.
hemodynamics as
So
well as
it's
saturation.
causing a tension actually and
yeah.
further
Who wants
worsening
to
the
put an
RV
ICD?
failure.
Who is going to insert ICD?
Yeah.
Give him ICD.
So preferably
The
before that,
sonologist has marked the place for ICD,
Yeah.
so you can insert ICD from that side.
Make sure lines are clear.
and the lines and everything was fine.
One of you check the lines window.
Meanwhile,
And
just
check
check
the
the pump if
Check
any.
the ventilator
Yeah.
vent settings and also
Anything, is there
increase the
any air or
one
any
has to
vasopressor
look
levels.
at the vital parameters.
Vital
Sir,
parameters.
can we add vasopressin during the procedure?
You want to
Sometime?
add?
Yes,
Whatever
sir.
you want, you do. It's your patient. You let me
So
know.
We don't want the patient once the ICD
I-
is placed,
I-
it's completely
So
the
you-
parameters.
Whatever you say, I'll do it. It's your patient. I am just a nursing staff. Tell me how much ml.
One unit per hour, sir. 1 unit per hour.
So we
No,
have
1
40
ml.
units, 40 ml.
1 ml per hour.
1 ml per hour.
Yeah.
Okay. Vasopressin started 1 ml per hour.
After load.
Is safe, right?
So it's scrubbing.
I think the circuits and everything is fine there.
Yeah, he's
Everything
checking.
is within normal limits.
Is any
So we'll plan for
anything?
ICD once I. And
urine, everything is fine?
We
There's
will
no
also
bleeding
plan-
anywhere else, no? Did
No
you see
immature,
picture?
yeah.
so he'll be
No
putting the
bleeding
ICD.
externally, no
Meanwhile,
clinical evidence of
we'll
bleeding.
plan that
Yeah,
if there is any complications, we should be ready for that because placing an ICD, he might have another scenario of
Cardiac
cardiac arrest.
Yeah.
So we'll
Yeah.
be
So we'll
ready
keep
with
the
the.
drug cart
Emergency
with
drugs
emergency
ready,
drugs.
sir.
We'll keep if I had to
Airway cart,
100%.
emergency cart loading with emergency medicine.
And fluid for
Adrenaline,
transfusions.
atropine.
Yeah, fluid for transfusions and as well as any blood products which are needed, which will be
Yeah.
ordered
We'll
prior
keep,
that because after placing the ICD, if they drains the
Yeah,
blood,
So
they
before
will.
that,
Can
even
we preload
coagulation
that?
profile also,
We have al-
platelet count is 96 and
And,
Can
ACT
we
is
preload the
150.
patient prior to putting an ICD, please?
I'll get it.
Can we give more fluid before
Yeah,
putting
yeah,
an ICD?
yeah, we
As
have
we are
alread-
expecting hypotension.
Yeah, we.
Just now we have ordered.
No,
Yeah.
if
We are-
when the drainage is there, venous return should improve.
Yeah, but-
We'll just give it.
If-
Okay.
To
So-
prevent crash.
If there is any crash medicine, he will be taking care of the ventilator. We will be going for the emergency
CPR.
resuscitation as
Now
well.
I am taking
Where
care
is
of
the ambu?
ECMO machine.
Ambu.
Yeah.
Keep the
ambu is there, sir.
Oh.
So we'll keep.
So the vitals on the ventilator are stable, as well as the vitals on the monitors are
Same
also
vital.
being stable.
Except for
The
left
incision is
also.
done. I mean, he has given local. The pressures are stable. The saturation still on 82, and the BB is 96/63, which is on the lower side. The heart rate is 130.
And now the patient on noradrenaline 0.3 mics.
Sedation is adequate. He's not woken up, no?
Yeah,
Okay.
yeah.
And one of them ready with the clamp, be ready with the clamp, will clamp with that clamp. So
Will
much
ensure adequate sedation
initially
paralysis.
drain only 250 ml of blood, not more of the draining. Will gradually drain the.
No, it is septate, so we don't know.
Yeah, there is a,
Blood is coming.
yeah, it was a hemothorax.
Pneumothorax.
It's
Yeah.
draining. Check with the blood pressure. Yeah, blood pressure improved
bit.
96/63.
It's
No, we
still
have
on the
started
Saturation is
advanced.
still
one.
82. We'll
Same.
wait for it.
Yeah. We'll fix it.
So position is checked, and the column movement is fine. We
Yeah.
can
Yes.
fix it.
Yeah, there is column
Column is
movement.
moving.
We will fix it.
Yeah.
We'll order for a chest X-ray.
Move
post
around.
procedure.
We'll do a post procedure chest X-ray. We'll be ordering.
Yes.
But there is no increase in saturation still.
Post procedure chest X-ray.
Dynaplast.
And we'll send a set of coagulation parameters.
Then we order it.
Okay, sir. The blood pressure is improving.
Blood pressure is slightly.
Yeah,
Saturation
saturation
also is
improved.
The
improving.
saturation is
Saturation
also improving a bit.
Yeah.
Improving, yes.
Tachycardia is
88.
settling. Yeah.
Once again, we'll check with the patient, complete patient examination.
Nation.
Uh,
Yeah.
So
We'll make
whether
And since
detailed
you
exam-
already,
Good job.
yeah.
Yeah.
We have to restart the
so the patient is
So
on
we have to
vent-
decide on when to restart on heparin and
yeah,
Yes.
yeah,
Yes.
yes.
the level
After
of
2
heparin.
hours, maybe we can
We can
restart.
start
Restart the
with
heparin.
heparin.
We'll see with the flow of the blood, if it is continuously increasing.
That's
Uh,
why
maybe
we
we
need
can
to
call
closely
CT
monitor 1
surgeon
to
then.
2
Order
hours.
the ACT, after that we'll take a call with the, to restart or not.
So the first 1 hour we'll see the how much is the flow drain collected. After that we
The
can go
cover
ahead with
between.
depending on that we'll
Column
go ahead
movement is
with
good.
the-
Yes, sir.
Yes,
Yes,
sir.
sir. Yeah.
Yes. Column. How much is the drain which got after putting the SCD?
It's 200 ml.
200
It's
ml.
roughly 200.
So P1 also has remained the same, -16, so he's
Yeah.
not hypovolemic.
Circulatory, yes. Circulatory is normal.
The blood pressure is also increased and the saturations have increased. The heart rate has also come down. Now will we check the patient completely? So the lines are fine.
Yeah. No kinking or no obstruction.
No obstruction. The
Machine
color is
also
also
can you
fine.
cross check
The
everything
color
is
is
fine.
Yeah,
also
color
fine.
is
Color
good.
is fine.
Flows are
Pressures
all
are
We end
flows
the
are
scenario here now.
Sir?
We end the scenario here.
Okay.
Overall, well done. Before we debrief, can you just enumerate in brief what has made you think it is an hemothorax and how you did first?
It's a case of post cardiac arrest where the CPR was done. So there's a chance of hemothorax or pneumothorax post
With the
CPR. So that is the reason we thought of, and even the X-ray was showing a whitening on the right side.
X-ray got worse.
X-ray got worsened.
The patient
patient
desaturated.
was hemodynamically unstable as well.
Hesitant to put ICD, but since it was affecting his hemodynamics,
Hemodynamics.
we thought
We
of
thought of
going
putting
ahead
it.
with the decision.
We stopped heparin initially and we checked whether transfusions would help the patient, but it hasn't improved much. So we had to go ahead in putting ICD in order to improve the vitals as well as oxygenation.
Would you just like to look at the X-ray again and
Tracheal deviation also.
Any refraction?
Tube position is okay. La.
Written canal is more deeper.
It is at,
do you think there was some mediastinal shift?
Mediastinal
Mediastinal
shift
shift.
towards left.
Towards left.
Yeah, trachea shift is slightly towards
The patient was going into a tamponade.
Tamponade.
But ultrasound would be better option here to check.
This is
whether-
the post
ICD.
Nice.
ICD X-ray.
ultrasound also you could have seen if at all there was a pressure effect on the RV.
So your decision of putting an ICD could have been little early
Okay.
because the patient was going, and the BP drop was not because of blood loss, but it was because of the
Tamponade.
tension
Tension pneumonia.
Okay. And that's the reason there was not much response to blood
Transfusion
Transfusion.
or stopping heparin.
Okay, fine. So what are the cause for bleed?
Because since last
Because we
patient,
have
last
maintained a
time they
higher
had a
ICP.
pump clot that
Pump
increased
clot.
the dosage of the heparin,
Heparin.
which has leads to chance of
Probably
bleeding, and also the post cardiac arrest there must be some
Bad lungs,
bad lungs.
Bad luck.
CPR,
CPR.
and increase
Increase in
in
ACD
coagulation.
Bad.
Okay, fine. So that has led to hemothorax, and now you put an ICD. Okay, fine. Anything else you could have done before putting an ICD?
Lung ultrasound we could have checked.
That you have done, and that you diagnose only on the basis of
On
lung
the
basis of-
ultrasound.
yes, sir.
Okay. Why not pigtail?
It can
You
get
said
blocked
cavitation was
cavity.
there, and
One
it's a
is
blood,
cavitation and
how
it
much of
was-
drainage.
Yeah.
And it's
We
a
are unsure about
hemothorax.
whether it is pneumothorax or hemothorax.
Pigtail can
And
get
we stopped
clotted
heparin
also.
also.
Heparin.
We have stopped heparin also. It can clot.
High chance of clogging of that pigtail.
Pigtail.
So,
And
But
again,
By
we have to
ultrasound
go
we
for
will get more.
If there was no septation,
still, sir, still
Even then, we'll
hemothorax.
go with ICD. Sir.
still you would have
Still
gone
like
for
that.
ICD. Okay, fine. Okay. Anything else you could have done before putting an ICD?
Release the tension by, if at all it's only pneumo.
It's not.
nothing. If it is causing a damage,
No,
not a
no,
blood
no,
clotting,
yeah.
if it's a pneumothorax, that would be
Okay.
fine. But
You asked for rotem and blood.
Yeah,
I didn't hear you to reserve any of the blood
Yes,
products.
products, okay.
Product.
Should have reserve.
Reserve.
before putting
You didn't
ICD,
ask me PTINA, you didn't ask me APTT, you didn't ask me hydrogen. This is day 20 of
20.
patient on ECMO. Hydrogen is likely to go down.
Ask an actual
So
population
preparation
profile.
for a procedure was there but not adequate.
We have asked
You
only
would have
ACD,
been more concentrating on the, you asked for
Clinical.
rotem which takes half an hour or so. You could have asked for a simple test first. INR, APDT, fibrinogen levels, because that is very important.
That
you
would
could have
take
kept,
more time, sir, rather than rotem.
yeah, but then you should have some reports in your hand before you
Puncture.
put an ICD.
I see.
At least you should have
We could have
or
reserved at least.
empirically reserved it at least, so that after then you can start. Platelet count was 80,000. That was okay for putting an ICD.
ICD.
But rotam will get sometimes in 10 minutes. With the 10 minutes, we
10 to
can
10
make a
minutes,
decision sometimes. At that
Yeah,
would
but
be-
if you have a in-house rotem,
And even having a plasma in hand, when you are running, if the patient starts bleeding, then probably you have to administer and you are running for it. At the end of it, when patient has started massively bleeding. So you see, blood and blood products should be
Should be
ready.
arranged.
Whether
Ready.
you use it
Use
or
or
you
not.
don't
No.
use it, that is a
Yeah,
different
yeah,
issue.
correct.
and especially an ICD,
I
if the blood products reserved,
Ready.
it's likely to bleed. So you have to keep it reserved. Blood, you have kept it, but you stopped heparin immediately. That was a good thing that you did it. But about the products, you have to be more mindful about the products. Okay. If it would have been just, I would say it was a pleural effusion of around 600 ml or so, what would have been your decision?
We'll wait and watch, sir. If
There's no-
hemodynamics are
Hemodynamics are
stable,
not
Hemodynamics are not
there is
affected,
no
we can wait and
compromise,
watch.
wait
Wait
it.
and watch.
No, if hemodynamic was not stable, then
Single tap would
If there is an
Or
Single
pigtail
tap,
catheter would have
mediastinal
been
single
shift
tap
or
or
anything
pigtail.
causing pressure.
for 500 ml, would you like to tap?
No,
You think
actually
500
we don't
ml
like
of fluid
to
is going to
tap
cause
on
hemodynamic disturbance?
No, no,
No.
sir. I'm
You
like,
should think out some other cause for hemodynamic
We'll try to make him
instability.
little bit negative for the
Yeah,
patient.
that's
Yeah,
it.
other
Nothing to. So don't. What we say, don't put an ICD for a mild to
Mild
moderate
effusions.
effusions. You will burnt your finger. We have already done that. That's the reason we are telling you. Don't ever do that, because putting an ICD is the last thing any ECMO specialist would like to do it. Okay. Those who are practicing ECMO, all of them know, isn't it, Nanda? So we never want that. That is the last thing we want that happens, that we need to put an ICD in our patient.
Any procedure on anticoagulation is difficult, and you end up chasing the tail kind of thing. Once you put the drain in, because you're going to start heparin. I mean, what are you going to do heparin now? You can't stop it forever. At some point, you have to restart it,
only transient.
and then you're going to start oozing again, and more will come up. So you need to really justify it.
Yes. Anything you want to add?
No, sir. Absolutely fine. Preparation is very, very important. Until you have landed with the emergency situation like a tension pneumothorax. Otherwise, you have to prepare yourself well before doing anything. Otherwise, once the complication happens, then it becomes a big challenge. Right?
Yes.
Fine. So, thank you. Any questions you have, or any questions from the audience?
Sir, if this patient starts rebleeding again after 2 hours when we're going to start the heparin, then how are we going to manage this patient?
Probably you might have to keep heparin off for a longer time. We have run heparin-free ECMO for few days. Okay, so that is not an issue. One more thing, you didn't go up on the ECMO flow when you came down on heparin. That was one thing I wanted to ask.
No,
I just forget.
we went on the ECMO flow, sir.
No, still 3 liters.
2007.
In fact, when patient was desaturated, you increase the FiO2 to 100.
We didn't increase.
We didn't
the
go up on ECMO.
ECMO.
I didn't
Actually,
understand
we
the
were,
reason.
We were
thinking of
thinking
going
of
up on the flows.
But
discussing.
your ECMO circuit was doing well.
Well.
And I was told you very clearly, if there's something wrong with ECMO, then only go up on the ventilator.
Yes.
If something wrong with patient, go up on the ECMO. So you could have gone up on ECMO that time. You can have gone up the ECMO flow to around 4 liters or so. And the patient, you put an ICD and heparin was stopped. That was just to prevent the clogging of the oxygenator. So don't forget, these are small things, but that is very important.
Yes.
So whenever you stop heparin, whatever time you stop heparin, go up on the ECMO flow.
One learning point. Only.
So, be prepared for any procedure like in this condition. Blood product should have been arranged earlier.
Yeah, blood products should have been arranged. At least by the time reports comes, it was tamponades, we wanted to put an ICD early, but at least keeping the reserve blood product would not have a problem. You could have always decided after that whether to use it or not to use it.
So that point of increasing the flows.
Yeah,
during
whenever
when
you
we are
stop
doing
heparin,
heparin,
increase
we
the
increase
blood
the
flow.
flows and
Okay.
Weighing the risks and benefits of the procedure in a patient on ECMO, sir.
Yes, that is very important. Okay, don't just jump into the procedure. At the same time, don't keep on sitting on necessary procedures. Don't unnecessarily sit on it.
On images, investigation should be more careful. Like in X-ray, we didn't notice we missed the shift, the mediastinal shift.
shift. You have to be very mindful about it.
Sometimes routine investigations are very useful, like going for PT INR is important.
Yeah.
We may require any procedure at any moment of time. So.
That's true.
Always any hemodynamic instability, rather than thinking the current, think of even the yesterday's events could be triggering the events for today.
Yeah, so you should always know the trend, and that's why the handover is very important. Get a proper handover. This, if you see the last team, there was a clue that has been given to you. There was a transient stoppage of pump.
Yes.
Okay, that was an important clue. So don't miss a single clue. Okay.
Always invasive procedure should be in the last resort.
Yeah, don't just jump into it.
But never late also.
Yeah, never late.
Because
Never
if you
late
miss
also.
the time, then probably patient will collapse.
Yeah. Okay. Thank you.
Thank you.